Welcome back to Session 3, Surgical Management of Hemorrhagic Stroke, a Procedural Focus. In Session 3, we have the privilege of hearing from two distinguished speakers, and our first presenter of this session is Dr. Devi Patra. Dr. Patra is an Associate Professor of Clinical Neurological Surgery in Indiana University Health, specializing in cerebral vascular and skull-based neurosurgery. A prolific researcher and educator, he has over 150 publications and focuses on AI-driven neurovascular research and minimally invasive surgical innovations. As a reminder, you may find the full biographies of our speakers in the lobby. Dr. Patra, the floor is yours.
Thank you so much. Really appreciate Ms. Howard for this kind introduction, and it's really a privilege to be in this platform and discuss about this important topic. Probably, can I get the access for sharing? Okay.
If you want to go ahead and just click on the green share. Yep.
All right.
I see it loading.
Are you able to see my screen?
Yes, we are.
Perfect. All right. All right. Thank you so much, everyone, for joining this session today. I'm going to talk a little bit about the different minimally invasive approaches of ICH evacuation. We have briefly discussed this in the last sessions, but I'm going to discuss about what are the most options that we have at this time and how the evidence has been over the years, and how this has really changed the paradigm of ICH treatment over the years. I don't have any conflict of interest. Now, as we talked about the STITCH 1 and 2 trials, as you know, you have already heard that there has not been any benefit that has been shown with open surgery, with open craniotomy and evacuation. However, there has been a lot of talk about the MIS approaches, whether this is going to be a helpful option for treating this devastating disease, because it's less invasive to brain, and there's a chance that we might have a better clot evacuation, and of course, of the hope of improved mortality. Now, if we look at the guidelines in 2015 that was published, there was only a class 1 recommendation for evacuation of the posterior fossa cerebellar hematoma in patient with deterioration. However, if we look at the supratentorial ICH, there's not been much of kind of a recommendation. It's only class 2B, and we saw that the usefulness of surgery is not really well established, and effectiveness of MIS approaches has also not been established. So there's not been a strong recommendation even for the MIS approaches. So in this background, there are two main trials that we saw coming up in that era. Is the ICS trial for endoscopic evacuation, and the MISTI trial is essentially a catheter-based aspiration. These are the two MIS approaches which kind of laid the foundation of MIS approaches for the ICH evacuation, and that led to the further recommendations. Now, coming to the ICS, it was published in 2016, and the patients were randomized into 3:1, and the patient were treated within 48 hours. So what's done in this study was, using a stereotactic guidance, an endoscope was inserted with an obturator into the hematoma, and essentially, the suction was used to take out the clot. Interestingly, the endoscope was not really used to evacuate the hematoma, but it was used afterwards to kind of look for any kind of any bleeding points or any residual hematoma. So it's a little bit of different than a real endoscopic evacuation. However, and they use like 3 trajectories, one from the front, one from the back, and for superficial hematomas, more like a direct trajectory. So these are the 3 trajectories. It's kind of guided from the MISTI trials, and these are used to evacuate these hematomas. An average surgical time was mostly like 1.9 hours. So what we saw, the MRI 0 to 3, which is the primary outcome, is basically having a good outcome. In the surgery group, it was 42.9% compared to the medical group, 23.7%. And this kind of laid a foundation that probably there is some benefit with MIS approaches in the supratentorial hematomas, although this is not fully powered. Now, next, coming to the MISTI, so this was initially devised as an initial trial for to assess the safety. In the MISTI 2, we already kind of spoke about that. What was done in this procedure is a patient with more than 20 cc of ICH, and within 48 hours, they were treated, after confirming there's a stability. And the brain cannula with an introducer was used along the long axis. We talked about those three trajectories where, the brain cannula with the introducer it was used to enter in the hematoma cavity. And then initial aspiration was done with the 10cc syringe until the first resistance was encountered. And over time, after encounter resistance, that time a catheter was placed in the cavity. And after about 3 hours, 1 milligram per mil of TPA was given, letting it to kind of work with the clot for an hour and then allowing it to drain. So this was done about maximum 9 times. And the endpoint was either 20% of the original volume was, it's achieved, or the hematoma volume is less than 15 cc, or there is any complication like symptomatic bleeding. Now, with this initial safety trial evaluation, and we could see that, of course, when compared to the medical management, the reduction of the ICH volume was very much significant, and also in terms of safety standpoint, the death, any infection, or any symptomatic bleeding or asymptomatic bleeding, those are very comparable with the medical management. So this kind of laid a foundation that this is a possible option for patients with a supratentorial ICH. Now, interestingly, there was another trial which also kind of used the similar method, but additionally they used a ultrasound probe along with that catheter that kind of a more like a sonothrombolysis. So in this procedure, 9 patients were enrolled and for more than 25 cc of ICH, and the patient was treated within 72 hours. And this catheter was placed, and along with that, there is a probe that was also advanced to kind of sit in the clot. And this ultrasound probe was activated to allowing some clot lysis, and then it was allowed to drain. And what they found is that in the ICH patients, the 59% they achieved in clot reduction. In IVH, it was about 45%. The main thing that they achieved, that the clot clearance was a little bit faster compared to the MISTI and CLEAR-3. Now we kind of learn about the MISTI-3, which was essentially kind of to assess the functional outcome and the mortality with using this catheter-based aspiration in the same method that was used before. Unfortunately, this was mostly a negative study. We didn't really see a benefit with functional outcome compared to the medical management. However, a post-hoc analysis showed if we bring the clot volume to less than 15 cc, or we bring it to more than 70%, then probably there is some functional benefit. Now, with these 2 trials and all this evidence showing up, now the new guideline in 2022 from the AHA and ASA, we could see that there has some improvement, some kind of upgrading of the recommendation to 2A for these supratentorial ICH patients, which are more than 20 to 30 cc, using this catheter-based or endoscope-based aspiration. Now, when we look at the MISTI, why it was negative mostly, why we didn't really get a good outcome. So if we look at the limitations, these patients required a stable scan. So at least, some of the patients, they were not be able to treat it. Patients with a spot sign who has a high risk of hemorrhagic, expansion, they couldn't be treated. And only 59.9% had a hematoma evacuation to less than 15 cc, which was found to be functional, provide functional benefit. And the mean percentage of hematoma evacuation was 69.7%, and there was a little bit longer time that was taken to kind of bring the clot down, at least 72 hours or so. And there was no direct visualization when we took out the clot. Now, whether there is a new method that we can use to kind of improve the outcome. So if we evacuate more, if we evacuate early, or if we use some visualization to kind of, while taking out the clot, that way we can make sure that we're taking out enough clot and not leaving a lot of residual with the same MIS principles. In that scenario, there are 2 main MIS approaches that has been, used in different varieties, or endoscopic and using tubular retractor. Now, with endoscopic approaches, when we put the endoscope, there have been multiple devices that has been used to kind of take out the clot. One of them was, initially was Apollo. Now it is now with the Artemis from Penumbra. And this device, what it does is minimally invasive cranial access, can be used in a 14 millimeter bore hole. Let's see if we can play it. It's not playing. Anyway, so and then we can get a good control aspiration using neuroendoscopes with working channels for about 1.6 to 2.9 millimeters. Now, this is a 60-year-old gentleman with an score 22, and we use this Artemis device, and we could get a good evacuation. Of course, there has been a lot of edema and some hemorrhagic conversion of the adjacent parenchyma, but a good clot evacuation could be achieved. Now, another device is a Myriad, which is from the NICO, and this is basically like a handpiece with a side mouth cutting device, and along with aspiration, and it allows the clot to kind of macerate while using, and because it is the cutting device is inside the cannula, there's a less risk of damaging to vessels or any other critical structures, and this can be they come in different lengths and sizes, can be used in different scenarios. So this is a video. It's kind of showing how this Myriad device work, and it will be seeing how the cutting device is inside the cannula and allows the clot maceration and kind of breaking of the clot, some fibrous tissue while taking out the clot. Now, Dr. Kellner and group, they devised a endoscopic technique where it's called as a scuba technique, where the endoscope was introduced and was put in like about a 1.5 centimeter from the distal wall of the clot, and then the clot was aspirated, and the endoscope was gradually moved retracted towards the surface, and then once the whole clot evacuation is confirmed, then the whole cavity was injected with saline to make sure that the cavity looks good, and if there's a residual hematoma, that can be evacuated. Based on these findings, and you can achieve a good evacuation of the clot, and you can actually visualize if there's a residual clot. And with this technique, they achieved a very good evacuation volume. You can see that the less than 15 cc, which was the standard guideline to kind of take out the clot to this extent, was achieved in about 86% of the patient. And the evacuation percentage was about 80 to 88.2%. And the good thing about that, with this technique, they also showed that there's less amount of any symptomatic bleeding. Acidotic bleeding just control any. So to now, this also used patients who are not really included in the trial. Now, this is I think we will be talking more about this. Were treated within 24 hours, which is pretty early. And they used the brain path device, which is basically, we talked about a little bit that how we can use this brain path device as a MIPS approach, where it's basically like going through the parafascicular trajectory. We can avoid any kind of, any long tract or any kind of commissural fibers that may affect the postoperative outcome. So with this approach, they could achieve a very good, outcome. So now this is one of the video from brain path. I hope it's gonna play. Sorry, it's not playing, but this is basically how the brain path can be used to put into the cavity of the hematoma without really damaging the brain fibers. Now, in this study, we could see that there is a functional benefit with patients who achieved a good evacuation, and we can see that patients with MRS score 0 to 3, they really did well, and we had a good percentage of patients with good functional outcome with patients who underwent surgery compared to the control group, which were the medical management group. So this is another study, which is a MIND trial that recently was kind of completed, in the sense that this was also a study which was designed to kind of have MIS approaches in these patients. However, in the meantime, the Hemorrhage trial was published, and they could show that most of the benefit is mostly for the lower hemorrhages compared to the compared to the deeper hemorrhages like thalamus or basal ganglia. And you can see in this study, most of the patients were in the deep bleed category. So this study was stopped early because the positive results when reached only showed in for the lower bleeds. And whatever data that they had, they compared with medical management, and they didn't really see any improvement with 30-day mortality or 180 days disability in patients undergoing MIS approach. Now, this is a recent meta-analysis that kind of compared a lot of high-quality randomized trials to show whether there's been benefit with MIS approaches, and they found that there is a higher odds of long-term functional outcome, about 1.5 in MIS approaches compared to patients who have medical management. Also, they showed that there is a lower odds of long-term mortality and also a lower odds of early mortality with MIS approaches. So now with this now we have more and more evidence that the MIS approaches really does decrease the mortality and also improve the functional outcome. Now, there are some ongoing trials in endoscopic world, Invest trial, which recently completed and published the results, and we're still awaiting the paper. And this really enrolled patients with more than 30 cc volume and a score more than 6, and they excluded the spot sign. The patient was treated within 6 to 72 hours. There's another trial, the Dutch trial, as a DISC pilot study, which also included patients with more than 20 cc. Only thing that they are more inclusive in that the spot sign were included, and patients were treated early in the less than 12 hours. Is still ongoing, and we're awaiting the results. Hopefully, it will show some positive results. Now, what are the futures? So now there are different methods that we are also kind of experimenting whether to improve how we can improve the clot evacuation. This is one of the catheter that has been used mostly in IVH patients. It says IRAFlow, which basically works as a fluid exchange system, where it has two channels, one for irrigation and one for evacuation. That's how it is helpful in kind of evacuating the clot, and it can be placed for longer time to kind of allow some of the clot evacuation even after the initial thrombolysis and drainage. Now, this is also, there has been multiple reports about using robots for clot evacuation, mostly for good accuracy and good navigation. And also this oral surgiscope, which is from Integra, this also allows the same tubular retractor along with an imager, which allows a good visualization directly in the cavity, not really relying on any other light source. Also, it comes with a evacuator, which also combines the use of aspiration and suction and irrigation. Along with it, has like a bipolar tip that you can use if there is any bleeders that if you see in the cavity. And there have been different studies that have been ongoing with the surgiscopes, the mirror, and the evacuate study. I also want to kind of briefly talk about like our experiment that we did at the Mayo Clinic when I was there. We used along with MRI interventions, we devised a catheter. It's called as the clear point Persa device, which is MRI compatible catheter that we can use to evacuate the clot from clot under real image guidance, like live image guidance under the MRI. Now, the MRI catheter, this catheter is connected to the frame of the clear point, and we get in good accuracy about placing the catheter in the hematoma cavity. These are some of the phantom studies that we did with different clot volumes, and this is the pursuit catheter, and so what it does, what we do is the patient is brought into the MRI. Then we initially a registration scan is done, and then once the clot is seen in the MRI, then the frame is attached to the patient, and then another alignment scan is done, and then the trajectory is planned, and then the catheter is placed. And once the catheter is placed, and then another scan is done to confirm the location. And once we are satisfied with the location, then we can aspirate the clot under live MRI imaging to see how, how much clot is remaining. And this is, you can see the aspiration of the clot directly under the imaging, live MRI imaging. And that will confirm that we have achieved adequate clot evacuation. And this is kind of the live video where the catheter is placed, and then catheter is aspiration is done, and you can see the clot is evacuated under live image guidance. And with that, we achieved pretty good evacuation volume with the post-aspiration volume of 8.7 cc, and we achieved the standard less than 15 cc of clot, residual clot in these models. So coming to some of the pros that we know as of now is that the minimally invasive approaches are still evolving and is being evaluated in multiple trials. And we know that endoscopic and catheter-based evacuation techniques, and recently the INRICH trial using tubular retractors have been shown that it is effective and is safe. And there has been strong evidence that is emerging showing improved mortality as well as functional benefit with MIS evacuation approaches, especially in the lobar hemorrhages. Thank you.
Thank you so much, Dr. Patra. We're going to take a turn and introduce Dr. Simon. So we will hold our Q&A until after Dr. Simon's presentation. One moment. So welcome our next guest and our next presenter. Dr. Scott Simon is a professor of neurosurgery at Penn State, chief of cerebral vascular surgery, and director of the endovascular fellowship. Trained at Vanderbilt, he leads research on stroke, thrombectomy, and cerebral hemorrhage. He is dedicated to advancing cerebral vascular care and mentoring future neurosurgeons. Please note that the full speaker biographies are available in the lobby of the Zoom events platform. Welcome, Dr. Simon.
Thank you very much. It's exciting to be here. Give me one moment to power up the talk. All right.
Looks great.
So, we've heard a lot, and some of this is going to be a little bit borrowing from the other presenters because all of these topics overlap, of course. But we're going to be focusing on the technology and the technique that we used in INRICH. So I have nothing to disclose that's pertinent to this talk. So this is the outline of this brief talk. First, we're going to talk about minimally invasive surgery in neurosurgery and what that is. We'll look at the background and the rationale for MIS in intracerebral hemorrhage. We'll take a quick look at the inclusion and exclusion of INRICH, and then we'll go over the procedure. I've sort of broken it down into targeting and trajectory, positioning, craniotomy, evacuation, hemostasis, removal of the tube, and then follow-up pictures. And there will be operative videos in these for those of you who might be more sensitive. So minimally invasive surgery. So this means using a tubular retractor that's placed along and not across the white matter tract. So I believe we've seen this in one of the earlier talks today, but this is the retractor here with the blue obturator. And notice that it's going in between the lumps and into the space, and it's not crossing these fibers. They're certainly not being careful to cross this in a minimal way as possible. And here's a cartoon showing the retractor in, and they're trying to get out this cavernous malformation by being in between these long tracts and not crossing them. So let's take a look at what this looks like in a clinical context. This is from another paper about taking out this was taking out tumors. And you can see they're going along the axis of the fibers, getting to the mass, and then you can operate within this channel that it creates. And this is MRI data from the same paper. And you can see they have white matter tracts being deflected by the mass. So what they don't want to do is come across this way and go right across those tracks and in theory injure them to the point where they might not recover. Much safer and smarter to come along the tracks to operate on your mass. Once you're operating, it's no more or less damaging to the tissue than other approaches, but getting there is, at least in theory, much safer. So when we look at the background of the rationale, we've heard this before, that Stitch did not show a benefit of early surgery. Stitch 2 suggested a benefit for superficial lesions. So people thought that the difference here was that we were cutting through too many deep brain structures to get to these ICHs. So perhaps a safer, less invasive way of removing blood could result in a positive impact, positive outcome on ICH. So this is a cartoon from a paper that sort of went over that rationalization. And the thought was, if the bleeding moved the fibers this way, you were much smarter to come over here rather than trying to cross some of these fibers over here. So let's look at some of the exclusion and inclusion for Enrich, which was designed to test this principle. So the volume of ICH was 30 to 80. The GCS target was 5 to 14, so that's very broad. And it does include people who are in a coma, but it's trying to exclude people who at presentation are so sick that you can't possibly make them better, regardless of the intervention. The Hemorrhagic stroke scale had to be greater than 5. So the thinking there is you want to remove people from the trial who are doing so well, they're going to do well anyway. And that would be a ceiling effect. Treatment had to be initiated within 24 hours. So who was excluded? Well, if you had an uncorrectable coagulopathy. Now, if you had a correctable coagulopathy, you could go ahead and be treated. Since the trial has excluded or finished, there have, of course, been new ways to correct coagulopathies. And so that would put someone sort of in the treatable category. As we talked about, Glasgow Coma Scale less than 5, so sick that no treatment was going to make them better. Interestingly, if IVH was greater than 50% of either lateral ventricle, that was also an exclusion criteria. The thinking being that these techniques don't really evacuate the ventricle per se. So if someone has a tremendous amount of blood in their ventricle, that could be what's driving the bad outcome. And the minimally invasive technique would not address that. So it's not that you can't use these techniques in patients with significant IVH, but when we're specifically trying to evaluate whether this technique is any good, those people were not in this trial. Initially, it did start with thalamic hemorrhages, but these were removed due to futility. And then intratentorial hemorrhage was excluded because we know that getting these out makes a huge difference. So there was no need to test those. It doesn't mean, again, you can't use this technology in those hemorrhages, but this trial was trying to establish efficacy, and that efficacy had already been established for intratentorial. And this one specifically wanted to avoid secondary causes of ICH, such as a ruptured aneurysm or an AVM. As we'll see in our case discussion, you certainly can use this technology in either of those. But again, what drives the outcome for those are other factors beyond the ICH by itself. And so they were excluded from this evaluation. So the procedure for the Enrich was a small craniotomy, image-guided access using the NICO brain path, evacuation suction, or using the Myriad device. You did not have to. Hemostasis per the surgeon judgment. So how much you got out, it was your best guess. Of course, we were going to check on a postoperative CT scan, but it was whatever the surgeon thought was best. And then replace the bone flap. So here you can see the retractors and then the obturators that go into them. And you can see that the tip is relatively blunt, but nonetheless tapered. And it extends beyond approximately 1.5 centimeters beyond the tip of your retractor. And that's very important when planning where you're going to stop entering, because the tip of your sheath will not be as far as the tip of your obturator. This is a marketing picture for the Myriad device. And as you've heard already, it's basically suction with a little tooth that oscillates so that if clot gets stuck in there, it can chew it up and continue being a working suction. So our residents have lovingly called it the angry chipmunk, because the little tooth just goes back and forth, back and forth, back and forth. So how do we want to target these? You want to go down the long axis of the clot because the retractor is long and thin. And so you expect the brain edema to push the hematoma into the retractor. Also, you want to go along the long tracks and not cross them. So in theory, at least, minimizing damage to the brain tissue that's not involved. So this would be a no-no. This is a video from Dr. Patra, who was the first author on the ENRICH study, just showing an animation of the trajectory. So you plan you outline the lesion, and you can see on the top picture there, the retractor descending into the clot, doing its best to follow the fiber tracks. And here's a close-up of that retractor entering. So positioning. This was from a paper that talked about an infertorial positioning. So this would not be how someone exactly was positioned for the ENRICH trial, but it gives you an idea of the OR setup where you need to be looking at a stereotactic monitor. And you make a small incision and a very small craniotomy, and that's where your tube goes. So if we look at this paper and you think about the trajectory that would be the best for this, this is going to put this right over the eye. And you can see this is a reconstructed CT scan afterward showing that this is the bone they removed. So you can make an incision in the eyebrow, lift the skin up, make a craniotomy here, and this will give you the trajectory. So where you put the hole is determined by where you want to end up, keeping in mind that your device is straight. This is an intraoperative picture that shows the size of the craniotomy. And here, Dr. Patra is making a slit in the arachnoid and pia, looking to get into this sulcus. And these are the dural edges with a stitch through them being pinned back so they don't flip in the way. And this is about the size of a quarter. So for those of you keeping track at home, you might ask yourself, why do we need a craniotomy the size of a quarter if our device is about 15 millimeters in width? And the reason is you need to be able to move back and forth. You need to be able to wand, as we would say. One is because your neuronavigation might not exactly be perfect. And the other is you want to be able to see your entire cavity. So you very well might want to move back and forth. You obviously can't go crazy and windshield wipe the brain parenchyma, but a few degrees in either direction will allow you to see significant more of the clot. This is a video from my friend Justin Singer, who unfortunately left us too soon, but this can be found on the internet, and this is entering the clot. So he's looking at a monitor. Obviously, you can't look at the tip of this at this point. Also, this is the stealth probe that has a proprietary fitting inside this, so it fits very nicely. Then you go ahead and pull your obturator out. And this is what you're looking at. And you notice Dr. Singer is going to pull out a big glob, a very large booger. I'm not sure there's any more technical term for it. And I would say that this happens in 9 out of 10 cases. You do get liquid clot, but then you get, if you're careful and you massage it, just a big fat one like that. And it's extremely satisfying as a surgeon. Often you can see the brain relax around the retractor after you get that out. I'm going to show it again just because I find it so satisfying. Carefully pull it out, and almost the whole hematoma comes out as one. And then it's time to dry up. Dr. Singer here is using some Surgicel, and you can hold this against the wall, or you can leave it in, and then you would use irrigation. As long as the water comes back clear, you know that there's no bleeding that you can either see or no bleeding that source you can't see. I use Surgifoam, but it's totally acceptable to leave behind hemostatic product. And then we pull our tube out. Go slowly, making sure no bleeding shows up in the cavity or along the tract. And you see you still have the track there. I'm going to show that again and hopefully do a better job of stopping it where I want. I'll give myself one more chance and then pulling out. There, I got it. So what I wanted to show here is, first of all, you can see this big hole, and the patients almost all immediately go to CT scan to make sure you got it all and make sure there's no rebleeding. And this hole on the scans, as you will see, is closed up by the time you make it to the scanner. It completely collapses on itself. The other thing I wanted to show you is, if you remember initially, this was all very tight. In fact, you couldn't see any space. But now I'll let it play again. You can see the cardiac pulsations because the decompression has lowered the ICP. You can see it moving there because now the brain is no longer under pressure. So this is from that paper we talked about before, and you can see the postoperative scan shows an excellent hematoma evacuation. This is one that I did. You can see I started a little more lateral because I thought that was a good way to get in here. And what I want to point out is this air here at 12 o'clock. So we'll talk about this more in our next session, but you might be wondering, what does craniectomy play a role here? Do you have to take off this? You've got the blood out, and hopefully that helps decrease cytotoxic edema and ferroptosis and the cascade that you've heard about from other presenters. But do you need to take the bone off to decrease the pressure? And you notice here, if you get that clot out, the brain relaxes a lot, especially in that 24-hour period. The edema has not progressed so far that you need to take the bone off. This comes from a paper by Dr. Kellner, who we've heard referenced, who's an innovator in New York, but this has been modified by my friend at Northwestern, Dr. Babuk Jerome, and he's added the trials here to the devices. And you can see the varying sizes of the retractors. And the Enrich is one of the larger ones, although we're talking only a few millimeters. And currently at my institution, we're trying this out, which Dr. Patra showed you, which is a little bit smaller. And then Misty and Mind use these devices. So it just gives you an idea of how small and minimally invasive we can get. And we're hoping to demonstrate that we can take out the deepest clots safely. Well, we've shown that we can do it safely. We want to show that it has an impact on outcome. So that's the end of my presentation.
Thank you so much, Dr. Simon. Again, really positive feedbacks in the Q&A that the videos are just so incredibly helpful. Just one couple of quick questions before we move on, because I do feel like some of the questions will be answered during the case study panel discussion. But one of our questions indicates they may have missed, but for Enrich, was there a cutoff age for inclusion?
Yes, 80.
80, okay. And then
18 to 80.
18
so this
to
is
80.
not tested in children.
Thank you. For those of you who were part of the research trials for Enrich, were there barriers to consenting patients or family for this research?
No, I didn't. I thought there was a sharp learning curve. Like the first case, it's a new set of technology. I'm not a tumor surgeon. I'm a cerebrovascular surgeon. So this is the primary place that I would use this technology. And it was definitely, the staff and I were fumbling around a bit, more than I care to admit, for the first couple of cases. But once we got it, it was a flat learning curve. But getting patients consented, you know, we're all major research centers, and we have professional staff who know how to do this and know how to handle sensitive situations with aplomb. And so that was not a problem.
Thank you. Just another comment, the enthusiasm for the blob of hematoma removal was appreciated.
Best part of my day, many days in the operating room.
Very good. In order to keep on track with our next presenter, we will just close the Q&A session at this point. So thank you, Dr. Patra and Dr. Simon. We will move on to session 4. So if everyone wants to leave this session and click the link in the resource tab to move on to session 4. Thank you both again.